Well, do you want to just tell me when?
Okay. Hello, everyone. Thank you all for attending our session today. We have the pleasure of hosting Dr. Colvin, who specializes in orthopedics. And as always, please remember that the Google form will be posted in the comments at the end. With that being said, Dr. Colvin, you may start whenever you're ready.
Okay.
Let me share it. Okay.
Okay, great. Hi, I'm Dr. Alexis Colvin. I'm a professor of orthopedics at Mount Sinai in New York City. And today I'm going to talk about anterior cruciate ligament tears and take you with a patient from the office all the way to the operating room. Next slide, please.
One moment. Sorry, my computer. Are you able to see it?
Yes.
Okay. I'm not sure how I would.
Go back to present, I think.
Yeah.
To the right.
Oh, okay. I wasn't able to see it. Okay, cool.
Yeah. Okay. You can't see my pointer, right?
No.
Okay. All right. So we'll first go over a little bit of anatomy. So if you look at the picture on the left, that is a picture of the knee, and the person's head would be at the top and the foot would be at the bottom. And above the kneecap are the four quadriceps muscles. The red part is the muscle, and they come into the tendon above the kneecap and then the tendon below the kneecap. So the tendon above the kneecap is called the quadriceps tendon, and the tendon below the kneecap is called the patellar tendon. Then if we go to the next picture without the muscles on it, these are the, now you have to see the bones of the knee. So again, the person's head would be at the top and the foot would be at the bottom, and you're facing them. So you have the patella, which is the kneecap. Then you have the femur, which is the thigh bone, and the tibia, which is your leg bone. And in the center of the knee, you can see those two ligaments that make an X. So you have the anterior cruciate ligament and the posterior cruciate ligament. Actually, can we go back to that picture? And so they make an X, and that's why they're called the cruciate ligaments, because they make that cross. The white coating that's at the end of the bones is called cartilage. And then you also have something called the meniscus. So if you look at the picture on the right, the kneecap is taken away, and you can see that there's a meniscus on each side of the knee, the left and the right side of the knee, or we typically call them the medial and the lateral meniscus. Next slide, please. So there are four components that I'm going to go through in terms of seeing a patient with an ACL injury in the office. We'll go through the history, the physical exam, imaging, and then the treatment. Next slide, please. So here's a very typical presentation of a patient with an ACL injury. So the chief complaint that they're coming in with is right knee pain and swelling. And it's a 30-year-old male who presents to the office with acute right knee pain and swelling after he was kicking a soccer ball in a game. Next slide, please. It's usually a non-contact injury. And so what that means is that there's usually no one around and there's no one hitting them. It's actually the force of the twist in the knee that causes the ACL to tear. It's usually a pivoting injury and they're going really fast and they slow down and stop very quickly, for instance, to kick a ball. Sometimes you'll feel a pop, not always. There's usually immediate swelling, but not always. But usually most people are not able to continue the activity. So you wouldn't be able to go back and play in the soccer game or go back and play in the basketball game. Next slide, please. So these are the 6 things that I look for on physical exam. So we'll go through it: gait, effusion, range of motion, ability to perform a straight leg raise, the SLR, the Lockman test, and the anterior drawer test. There's a lot of other tests that we would use to test other ligaments of the knee, or for instance, for a meniscus tear, but I'm going to focus specifically on the ACL studies. Next slide. So even before a patient makes it to the room, you can tell a lot about a patient when they're just walking into your office. So when we assess gait, that's the way they're walking, and we describe it as antalgic or normal. So antalgic means that it's so painful they can't put weight on that side. And it's also important to note, are they coming in with some sort of assistive device? So for instance, do they have a cane or crutches, which is a key to telling you that they just can't put weight on that leg. Next slide, please. When you're doing a physical exam, the inspection is the first part of the exam. And of course, you want to see, do they have any scars from surgery? Is there any bruising? And then the next thing I usually look for is whether or not there's any swelling. So if you look at the picture on the left, that's a side view of the knee. So that would be someone's head is at the top, their foot is at the bottom, and they're facing to the right. So the kneecap is on the right side of the picture. What it's showing you here is that the pinkish area is called the suprapatellar pouch, and that whole area can be filled with fluid. So normally, if you don't have any swelling in your knee, there is a little bit amount of fluid in there called synovial fluid. That's sort of like the motor oil that goes in a machine, but it's not a lot and it doesn't fill up the whole pouch. But when you're swollen, that pouch can fill up and it's almost like you have a water balloon in your knee. So if you look down at the picture on the bottom right, what you'll see is there's two knees there. The knee on the right is a knee with no swelling. And so the foot would be at the top of the picture. And so you can see the contours of the patella well. If you look at the picture on the left, you can see that the bone contours are not as defined. And that's because the knee is full of fluid and it's filled up that whole pouch. So like I said, not every ACL injury has a lot of swelling, but if someone comes in with a lot of swelling in the knee, that's usually, that could be an indication of a bigger injury. Okay, next slide, please. So the straight leg raise is a very simple exam to do on a patient. It can actually tell you a lot of things without the patient doing very much. So if you just click once, what you'll see is all you're asking the patient to do is when they're in a supine or laying down position, they're just going to raise their leg up. So simple, right? But it's not so simple if someone has a bad knee injury because it might be so painful that they can't raise it. And in particular, there's two injuries that we want to make sure that they don't have as well. So if you look at the next picture, just click. If you look at the image on the left, so it's showing a side view of the knee. So your head would be at the top and your foot would be at the bottom. And the quadriceps muscle is the red part. Then connecting to the white part called the quadriceps tendon, which is above the patella and also below the patella. So when you have something called a quadriceps tendon rupture, so when you tear the tendon off the bone, that's breaking the connection that's letting you do that straight leg raise. So if someone can't raise their leg, one of the first things we think of is, did they actually disrupt, we call it the extensor mechanism, but did they disrupt the connection of the quadriceps tendon to the rest of the leg? And so that disruption can be either above the kneecap, so a quadriceps tendon rupture, or if you click one picture over, or a patellar tendon rupture. So this is a front view. So the person's head would be at the top and the foot would be at the bottom. The red part is the quadriceps muscle. And then the tendon is below the kneecap. And if someone can't do a straight leg raise, then that could mean that they have a disconnection in the patellar tendon part of the extensor mechanism. Next slide, please. The second thing I'll check for is range of motion. So with the knee, there's not a lot of range of motion. It's either extension or flexion. There's not much movement in the side to side planes. So if you look at the picture on the left with the blue circle around the knee, what you can see is that the left leg can fully straighten, and sometimes people can hyperextend, meaning that they can actually straighten more than completely flat. What you can see on the right knee is that they're not getting it completely straight, and they're actually have a few degrees of it bent. And so that's something that we really try to see in the office, because that tells us, okay, this patient has something that's limiting them from being able to straighten the knee all the way. And that could be swelling, or it could be pain, or it could be other things such as like a torn meniscus is getting stuck in the knee. And then the picture on the right is with the knee bending, so flexion. And you can measure this with something called a goniometer, which actually measures the degrees that the knee is bent. But in this case, if you have a very swollen knee, like I said, it's almost like you have a water balloon in your knee. So you can't actually straighten or bend it all the way. And that could be a reason why someone doesn't have the full range of motion. Next slide, please. So getting down to ACL specific injuries. So what the ACL does is it has two functions. One is it keeps the bottom part of the leg from coming forward, and it also keeps it from rotating. So when we do the tests, when we do a physical exam, we're checking to see are those abilities to bring the bottom part of the leg forward and rotate it, is that increased because you have the tear. So one way to think about the ACL is that it's almost like a seat belt that's restraining those two motions, the bottom part of the leg forward and the bottom part of the leg rotating. And so if your ACL is torn, you don't have that seatbelt anymore. So when you do these, when you do the physical exam on the patient, then they'll have something called laxity, where you actually can make them do those motions more than normal. So one of the things that I love about orthopedics is that so much of it is actually hands-on. And so a lot of the diagnoses, you don't necessarily need an X-ray or an MRI for. You can actually diagnose it by examining the patient. So if you are doing something called the Lockman test, what you're doing is you're putting the knee in about 30 degrees of flexion, 20 or 30 degrees of flexion. And if you look at the picture on the right, you take the bottom part of your hand and put it on the top of the tibia and try to bring the bottom part of the leg forward. When you're first learning how to do this, it's very difficult to feel. And so I would recommend that as you're going through your rotations, that you always check this test on the normal side. And that way you get used to feeling what a normal knee feels like. And then that way you can pick up what a knee that has a positive finding actually feels like. Next slide, please. The next test is something called the anterior drawer. And so the way I usually do it is similar to how it's shown in this picture. So the knee is at 90 degrees, and I will actually sit on the foot to stabilize it. You put your thumbs on the top part of the tibia, the lower leg, and then try to bring the tibia forward. And so if it comes forward a certain amount, then that tells you that the ACL is torn. And this is something, again, which you want to practice on the normal knee so that you get a feel of what it should feel like when it's actually torn. Next slide, please. And then there's something called the pivot shift test, which helps to check the rotational stability of the ACL. So like I said, the ACL has two functions. It acts as a seat belt to keep the bottom part of the leg from going forward, and it also acts as a seat belt to keep the leg from rotating. So the first two tests are something that you can do in the office. When someone is very swollen or very painful, it's pretty difficult to actually have them be still enough to actually do those tests, and you certainly don't want to put someone in more pain. The pivot shift test a lot of times is usually best seen in the operating room because it can be pretty uncomfortable in somebody who has an ACL tear that was pretty recent. But if it's positive, then it's also indicative of an ACL tear. So what you do is you have the patient laying on their back, you bring the knee up, and what you're trying to do is take the bottom part of your tibia, rotate it, and seeing if you can get something called the IT band to bring it back into place. So if you look at the picture, what it's showing you is that in the first picture, the tibia, which is the lower part of the leg that's to the left of the diagram, that one is actually sitting a little bit forward from your femur because the ACL is not holding it back. Then as you start to bend the knee, the IT band, which is this reddish structure on the outer part of the leg, will actually act as a secondary seatbelt and actually bring the bottom part of the leg backward. And so when you do this test in the operating room, you'll actually feel a clunk because you'll feel that the bottom part of the knee, the tibia, is actually going back into place. Next slide, please. So this is actually a video, but unfortunately, I think we probably can't play it because it may not have come over. So that's okay. I think it did it. It's just showing that you can actually do it in the operating room.
When I click it, it just goes back to it goes to the next slide.
Okay, that's okay. I think the video probably didn't come over
Oh, okay.
with it. So then in terms of the next steps in evaluation, usually the next thing is x-rays. So if you go to the next slide. So the x-rays are important for a number of things. One is, of course, when someone comes in and can't put weight on their leg or had an injury, a lot of swelling, the x-rays are important just to make sure they didn't have a fracture or anything broken. Even though an ACL is a soft tissue structure, there actually are x-ray signs of an ACL injury, because what can happen sometimes is that a little piece of bone will actually get pulled off when the ACL is torn. And you can actually see it, not from the ACL itself, but from another structure. And you can actually see that little fleck of bone on the x-ray. It's also important for a number of other reasons. One is when you're growing, the bones don't grow, the entire bone doesn't grow. It only grows from certain parts called growth plates. And so what we do with the patient can sometimes change depending on whether or not they're done growing. And so we look for whether or not something called the physes, which is the growth plates, are closed. And then the third thing I put in there, DJD, is degenerative joint disease or arthritis. So if someone has a lot of arthritis, meaning that the cartilage is really worn down in the knee, that may also change what we decide to do for an ACL tear. So let's say we got the x-rays, which I'll show you on the next thing. Then the next step is the MRI, if it's needed. And that usually will help assess a course for if there's any ACL tears or ligament tears. But it also tells us whether there's any cartilage or meniscus injury. Next slide. So I usually actually get 4 sets of x-rays because they're all telling me different things. The knee is a 3-dimensional structure, so you want to be able to evaluate it in all those planes. So if we're looking at these 2 views, they're looking at the knee from the front, and you can see that both knees are actually on this x-ray. And the reason for that is, again, because you always want to compare the abnormal to the normal. So these 2 x-rays actually are pretty normal, even though the knee is injured. The knee that is injured doesn't have any bony signs when you compare it to your normal knee that anything is fractured or broken. And so that's very important, because if you just get an x-ray by itself and you find something on there, it may be because there's an injury, or maybe because that's that patient's normal anatomy. And so that's why getting the x-ray of the normal side can be useful. Next slide, please. And then these 2 views are also showing us the knee from different viewpoints. So the x-ray on the left side is called the lateral view. So that's a side view of the knee. Your head would be at the top and your foot would be at the bottom. And then the kneecap is the structure that's sticking out front. And so going back to when we were talking about, can a patient do a straight leg raise or not? With a straight leg raise and not being able to do it, and if someone has, you suspect that they have either a quadriceps tendon tear or a patellar tendon tear, what you can see sometimes actually is that the kneecap will actually change position, and it will actually be higher than where it is on the x-ray. So a very simple way of checking to make sure the kneecap is in the correct place is if you look at the darker white line that's in the femur. I'm sorry, I can't point to it, but go a little bit more to your left and go up a little. So that way, yeah, right there. So the kneecap should line up with that line, give or take, a few millimeters. And if it's there, then you know that most likely those tendons are okay. When you have a patellar tendon tear, what happens is the kneecap can go up several centimeters above that white line. And so if you have somebody that comes in who hurt their knee, they can't do that straight leg raise, and you get an x-ray and you see that the kneecap is that high, then you've pretty much diagnosed a patellar tendon tear without an MRI, because that's really the only diagnosis that can cause that. And then if we look at the x-ray on the right, that's something called the patellofemoral view. So if you look at the bottom cartoon, what it's showing you is how you actually take the x-ray of it, but the picture to the right with the foot is showing you what that view is actually showing you. So it's a view where you're getting the relationship between the kneecap and the femur, as if you were looking straight down at your knee. And so all of these x-rays, the things that we're looking for are smooth contours, no breaks, good spacing between the bones. If you look at the way the kneecap is sitting in that groove on the x-ray, above the cartoon, it almost looks like a puzzle piece about to fit into a puzzle. And so that's exactly what you want. Okay, next slide, please. So let's say you see this patient either in the emergency room or urgent care or in your office. What is the initial treatment that you're going to do? Well, we still don't know if the patient or what they actually have torn, and they can't put weight on it. So the MRI, depending on what resources are available, can't always be done right away. But you know that the patient needs it because they had injury and they can't do a lot of the things that you ask them to do in the office. So the first thing that I would typically recommend is crutches and a knee brace. And that's really just so they can try to walk relatively normal. If you can't put weight on the leg, it's very difficult to walk normally. And sometimes you can wind up hurting other parts of your body. So the crutches are helpful because you can keep your weight off the knee. And you can also allows you to gradually put some weight on the leg that's injured. For the knee brace, that one really, the type of knee brace really just depends on how much someone's able to move the knee. There are some knee braces that'll keep you from being able to bend the leg, which is okay maybe for a few days, but you don't really want to have your leg completely straight for too long because it will get stiff and you're not really using the muscles. So a knee brace where you have the option of straightening and bending it, but potentially locking it in that position is usually more preferable, but sometimes that could be a little bit more expensive or hard to get. While I'm waiting for the MRI, or while the patient is waiting for the MRI, I'll usually just ask them to do some very simple exercises at home, such as if they can't do the straight leg raise, and I don't think that they've actually torn something that would keep them from being able to do it. So if someone has a quadriceps tendon or patellar tendon tear, they won't be able to do a leg raise no matter what no matter how many things you try, because you don't have that connection there. But in somebody who has an ACL tear, eventually they will be able to do the straight leg raise once the swelling comes down in the knee and once they're a little more comfortable. So that's something that I want them to try to practice doing at home, and they can do that with the brace on. And then I also ask them to just work on just gently bending the knee as well. So you're elevating and icing it, which will help bring the swelling down, and then the bending should start to be able to come back too. So this is just simple things which they can do at home while we're waiting to get the MRI. Next slide, please. So with the MRI, like I said, there's a number of things that we're looking for on there, but specifically in this patient, we're going to look for the ACL because that's what we suspect is the injury. So if you look at the picture on the left, that's a side view or sagittal view. The person's head is at the top, and then you have the femur and the tibia. And so the MRIs can take time to learn how to read because unlike an X-ray where you only have one view, with the MRI, you're looking at sections. So you're only seeing a little bit of one structure at a time. So the normal ACL on this picture, I'm sorry that I can't actually point, but if you go to in between the bones on the left picture, yes, right, you're right on it actually. So that's the normal ACL. So you can see it's dark and it kind of extends like diagonal from the upper right to the bottom left. When you have a normal structure on an MRI, it's almost like you could take a pen and trace it. So that one, we see like a distinct structure. If you go to the picture on the right of the screen where the yellow arrow is, just picture that that's the same view on the MRI, which it is, but now it almost looks like you had that black line, but then someone erased it. And so that's how we know that the ACL is torn, because you don't see the very distinct fibers of the ACL. Plus, when you have a lot of swelling or edema in something that's injured, you can get a brighter signal because of the fluid that's there. Next slide. And then the other thing that a lot of times is classic with an ACL injury is that you get bone bruising. So like I said, the ACL has the two functions that it acts as a seatbelt. So it's keeping the bottom part of the leg from coming forward and also the bottom part of the leg from rotating. So when the ACL tears, it's essentially like your seatbelt became unbuckled. And so the bottom part of your leg comes forward and comes out, but then comes back into your body. And the bones will bruise each other because they're colliding. And so if you look at this picture, this is a side view again. So your head would be at the top, the kneecap is to the left, and the foot is at the bottom. And you can see two brighter areas. I think if you could take the arrow and go to the top bone, go a little bit to your left. Yeah, the lighter gray area in the middle of the bone. Go a little bit to your right, right there, and go up. Go up like a centimeter. Yeah, so that area that's lighter is actually bone bruising. So similar to the way you bruise your skin or your muscle, you can also get that in the bone. And then if you go to the bottom bone, right there, yes, perfect. So that's the bruising that's in the bottom bone, and it's almost always in those two spots because that's where the bones hit when the ACL tears. So if you see that on an MRI, that's also something which you typically would really only get that if someone had an ACL tear. Okay, next slide. So in terms of ACL injuries, there's about 400,000 ACL surgeries that happen each year. And the highest incidence is usually in individuals 15 to 25 years old who participate in pivoting sports such as soccer, football. You don't usually see it in things like biking or running because those are activities where you just need to go straight ahead. You don't need to do too much side-to-side movements. Next slide. So what's actually happening here? So in terms of the forces that are going on around the knees, this is kind of a complicated picture, but what it's showing you is that that the pivoting knee, there's a lot of different forces that are causing the bottom part of the leg to come forward and then also to rotate. And that combination of forces, which is also extends from the hip down to the ankle, those all contribute to the ACL tearing. Next slide. So when the ACL is torn, the ACL does not fix itself on its own. The only way you can have a new ACL is to do surgery for it. But it doesn't mean that every person who has an ACL tear needs surgery. So in terms of who are the people that don't necessarily need surgery, well, number one is someone who has a lot of arthritis in the knee. And that's something that you would pick up from the x-ray in the office that you get when they first come in. So if someone has a lot of arthritis in the knee, sometimes their activity level is pretty low and they don't need it. But also people tend to be actually pretty stiff with arthritis. So when the ACL when the ACL is torn, the knee is unstable or it's a little bit looser than it should be. When you have arthritis, a lot of times, and you have a lot of arthritis, it can actually be stiffer. And so sometimes you actually don't feel the effects of instability with a torn ACL in someone who has a lot of arthritis. So that's a patient where you may not actually need to do surgery. Number two would be someone who doesn't actually have any instability with doing daily activity things. So someone is pretty much doing every activity they want to do, and then there's really no reason to do surgery. The reason to do surgery would be if someone said they can't walk around without the knee buckling on them, or they can't go back to their commute to work without their knee buckling on them, or maybe they're a construction worker and they can't do their job because the knee is buckling on them. And so those would be reasons to do surgery for the ACL in someone who wasn't necessarily an athlete but needed the stability in the knee and for their job or for just being able to do day-to-day activity. And then number three would be someone who doesn't need to do any cutting or pivoting activities. So if you have someone who is young and pretty active, they don't feel any looseness in the knee, they don't have any knee giving out, and they don't particularly want to go back to anything like skiing or basketball or football or soccer, and they're happy doing activities such as running or spinning, things where they're doing a linear motion or straight ahead motion most of the time. Those are people who may not actually need to have surgery for the ACL. Next slide, please. So then when we go to who do we do surgery in, so that would be kind of everybody else. So people who want to go back to those sports or activities where they need the knee to be stable. Those are the ones, and that we have the conversation about whether or not to do surgery. And so in terms of surgery, even though right now there is research on repairing the ACL. So when you tear the ACL, right now the gold standard for surgery is actually making a new one. So like I said, there's research on fixing the one that's there. But right now, the best way to restore the ACL is to make a new one. And so how do we do that? So there's two big buckets in terms of how to make the new ACL. So you could either use something called an allograft. So allo means not you, so one from a donor. So it's a piece of tissue either from around the knee or sometimes a donor's Achilles tendon that we would use, or something called autograft. So auto is yourself, so it's tissue from yourself. And the three choices below are the ones that are most common. Actually, if you go to the next slide. So we'll talk a little bit about the anatomy of, and then go on to how do we actually surgically fix it. So again, just to review over where all these structures are. So if you look on the left picture, this is a knee. If we're facing the knee, your head is at the top and your foot is at the bottom. And the arrow showing where the ACL is in the center of the knee. So when it's torn, if you go to the right, that's what happens. There's a disconnection between the ACL too. It's almost like a rope that's there. And so it can tear in the middle, like in that picture, but it can also tear off the femur, which is where it's attaching up to, or it can tear off the tibia, which is the bone that it's attached to on the bottom. Next slide. So when we do the ACL surgery, so the left picture is actually a picture in an anatomy specimen in a cadaver. And so this would be if your knee was bent and we're looking at a bent knee, this is where the ACL goes between the two bones. So because right now the best way to do surgery is to make a new ACL, the way we do it, if you look at the picture on the right, is we actually drill a small hole into the bone on the femur and then a small hole into the bone on the tibia. And then you literally thread this new graft, a piece of tissue between the two bones, and then you fix it with something. So there's a number of different ways to fix it, anything from screws to little buttons. So how you fix it is really not as important as just making sure you're in the right spot. Next slide. So these are what an ACL tear looks like in surgery itself. So if you're looking in the knee, what this is showing you is at the top picture, that metal object is a probe. So it actually has a little hook at the end, which you can't see because it's behind the ACL. And so what it's showing you is, again, it's almost like a loose seatbelt. So it's still there, but it's pulling away more than it should be. And then in the bottom picture, that's what an ACL looks like after surgery. So you can see it's nice and tight, and it's going between the two bones. So essentially, it looks like the first picture. It's just tight the way you want a seatbelt to be buckled in. Next slide. So this is what the setup looks like in the operating room. So the patient has general anesthesia, and then in terms of other anesthesia, you can also do something called a nerve block. So the patient is asleep, of course, and then when they wake up, they're awake, but you can also have a type of anesthesia where they have a small catheter at the top of their thigh that gives medication just to the nerves in the right leg. And you can either do that as a one-time dose, or you can give them a small pain pump to go home with, and then they take it out in 2 days. And that can help with the pain afterwards as well. Next slide, please. The surgery is done arthroscopically, so minimally invasive. And what this picture is showing you is that because it's minimally invasive, we need instruments to be able to reach all the parts without making big incisions. And so the two things on the table that have the black circles, those are actually the camera itself. And then to the left are different instruments. And again, you can see they're all long and skinny because they need to be able to go through a small hole and then reach to where we need it to reach. Next slide. So the only part of this surgery that's usually not done arthroscopically is actually taking the graft, so actually taking the piece of tissue that you need to make the new ACL. So these are the three autograft choices, so the three ones that are using your own tissue. So the upper left one is if you're taking it from the front of the knee. So this would be someone facing you with their knee bent. And that's actually the patellar tendon and then the patella. So there's a little piece of bone at the top of that graft and a little piece of bone from the bottom. And then the tendon is in between. The picture to the right is the person's head would be at the top and the foot at the bottom. And then you can see that the patella is labeled there. And so that would be taking a little piece of bone from the patella and then the quadriceps tendon, which is the tendon above the kneecap. And then the bottom left is taking some of the hamstring tendons. So this is a side view of the knee, and your head would be at the top, and your kneecap you can see there, and then your foot would be at the bottom. And so even though your hamstring muscles are on the back of your thigh, the tendons, those white or gray parts that connect to the bone, actually will come down the inner part of your leg, and those can be taken as well through a small incision, and you can make that into a new graft. So if you look at the bottom right picture, what it's showing you is that this is what a typical ACL graft would look like. So there's a piece of bone actually to the that's the left part of the graft, and we will put stitches through that. And then to the right part of the graft, the one where it looks like there's a little more blue there, that's also where the stitches are too. So you take the piece of tissue, and you need it to be a certain size, and then you put stitches on either end, because that's going to help you pass it through the knee. Again, we want to do everything through small incisions. So what that means is that there's a lot of shuttling with different stitches to go through different parts of the knee. Next slide, please. And again, this is what it looks like when you're done. So this would be facing someone's knee with their knee bent. And what you can see is that on the tibia, there's a small screw. So that would be the bottom bone, and the sort of tan. I don't know if you want to put your pointer on there. Go a little bit to your right. Go down. And the thing that looks like a circle that's tan. Yeah, so that's the screw on the tibia side, because you need something to hold the graft in on there. And then if you go to the femur, the top bone, and there's a screw in there too. And so you need to be able to fix the graft with two things. And this is one where they used screws. So, the sort of simplified version of what you're doing during the surgery, again, is that you have a small hole in the bone in the tibia and a small hole in the bone on the femur. And then almost like you're putting a shoelace through a shoe, you're threading this new graft through those two holes and then fixing it on either side. Next slide. So just a quick word about meniscus tears. So the meniscus has been showing up on every picture that I've been showing you, because it is another important structure in the knee. So, and a lot of times, I would say almost 50% of the time, you can tear the meniscus in the same injury that you tear the ACL. So if we look at the picture at the top and at the bottom, the meniscus are those two circle-shaped or half circle-shaped structures. At the top, they're sort of pinkish peach, and at the bottom, they're the pinker ones. And there's two general types of surgeries that we do for the meniscus. So when you tear it, you can either do something where you clip out the torn area, so the top left picture or the left side of the bottom picture. That's one where they just kind of clipped out the tear. And then on the right side of the top picture and on the bottom picture, that's one where the meniscus tear is actually sewn together. So the difference in those two as to why you clip it versus sew it together is the very dark pink on the bottom is in the outer part of the meniscus, because that's where, yes, exactly, that's where the blood supply comes to. Actually, if you go to the right, the one that says repair with suture. So if you look at where that tear is compared to the tear on the meniscus on the other side, one is in the very dark pink area and one is in the lighter pink area. So the dark pink area is showing you that that's where the best blood supply to the meniscus comes from. And so that's one where it has the potential to heal if you sew it together, versus if you have a tear in an area that's a little bit lighter pink, there's not really good blood supply there. So even if you sew it together, it may not heal, and then it'll tear back out again. And so this is something that we would do at the same time as the ACL surgery if the injury was present as well. Okay, next slide, please. So in terms of post-surgery, this is really where a lot of the important work happens too. So the first thing to think about is it can be a pretty painful surgery. And so that's why, with the general anesthesia, the patients also have the option of getting a nerve block. And then usually some combination of medications after surgery to help with the pain. But most people don't usually need the strong stuff past about a week or so. The physical therapy is also really important too, because even though before surgery, we want to make sure that the patient is walking normal and able to bend the knee, after you have surgery, it can be pretty hard to do those things too. So the physical therapy is a really important component of recovery after ACL surgery, because the ultimate goal is to get somebody back to doing their activity. And so the goals of physical therapy are really different at each time point. So in the beginning, right after surgery, it's really just to get somebody to walk normally again, to be able to move their knee normally, to get the swelling down. And then as you get, as you start to build strength and motion in the knee, then those goals become running or returning back to sports. And so that's, many months down the road. Like the bottom point is saying, going back to cutting and pivoting sports. So probably the activity in which the patient injured it in the first place, that usually can be, even 9 to 12 months after the surgery, because we want the graft to heal internally. Just because you fix it with screws, it doesn't mean that it's healed. It just means that it's holding the ACL in place to heal back to the patient. And then also how they progress with physical therapy. And then in terms of seeing the patient back in the office, I see them back at pretty regular intervals. First, just to get the stitches out, but then later on, just to make sure that they're progressing well with their activity. Okay, next slide, please. So I'm happy to take any questions if anybody has.
Are you still able to see it?
I can see the chat, yes.
Okay, cool. I will send in some questions.
Oh, okay, I think I can see the.
Oh, are you able to see my screen?
I can see your screen, yeah.
Oh, okay.
Do you want to go to the top one? Which one should I start with there?
Whichever you like.
Okay.
Someone asked, how did you decide on your specialty?
I think it was a lot of things. So I definitely spent a lot of time trying to learn about other specialties. But I think for me, I knew that I wanted to do something surgical. I think that's usually the biggest distinction that people make when they are first thinking about what specialty they want to be, whether or not you want to do procedures and see patients, or whether or not you just want to just see patients in the office. So I knew I definitely wanted to do something hands-on. There's a few things that I really love about orthopedics. One is that you're really helping to restore quality of life. And so, for instance, in this patient, now he can go back to skiing. I would tell you it's probably one of the most gratifying things to get an email from a patient or to talk to them and see that, like I just had one who was able to go back to skiing and hiking. And so to be able to help someone get back to that sort of quality of life is really, really gratifying. I think one thing that I've heard a lot of, I would say a lot of med students ask me is, well, if you go into surgery, your hours are really long, or those sort of thoughts in terms of scheduling. I would definitely say the best piece of advice that anyone gave me was, don't pick your specialty based on what you think the lifestyle will be, because you can always make your lifestyle what you want it to be. So, even I would say even the orthopedic trauma doctors who have to deal with, middle of the night emergencies and that sort of thing, they're not living at the hospital 24 hours a day, 7 days a week. You have partners who you split call with. I think you have a lot more control of your practice and the type of career you want to have than most people think. So definitely, if you're even considering doing surgery, I wouldn't let this, the training is tough. I wouldn't minimize that. But once you get through the training period, you can make your hours in your career the way you want it to be. So I wouldn't let potentially, a tough schedule for a few years keep you from wanting to do a specialty that you think you really might be interested in. All right. Here's there's a lot of questions here. I see one that's saying, what is the difference between the Lachman test and the anterior drawer test for diagnosis? That's a really good question. So with the anterior drawer test, your knee is at 90 degrees. and it's the easier test to do because it's easy to get somebody in 90 degrees and to hold their leg in that position. But the issue with that is that sometimes it's not as accurate as the Lachman test is actually a little more accurate because there's other factors that can keep you're looking for whether or not the knee is unstable. And so whether or not you can bring the tibia forward at 90 degrees. And so when your knee is at 90 degrees, sometimes there's other things that can keep it, like for instance, like if their muscle is really, if they're really like contracting their muscle, that can keep you from actually feeling that it's looser than it is. But when the knee is in the Lachman position, it's harder for somebody to do that. So that's actually the more accurate test between the two. It's just a little bit harder to perform. I know there's so many questions. Where should I just pick and choose, or?
Yeah, you can pick and choose whichever you'd like to answer.
Okay. Oh, my favorite type of orthopedic procedure, I would say actually probably ACLs. I really love doing them just because of how limiting it can be when you have a torn ACL, and then how much you're able to go back to doing once it's restored. The exercises that lower the risk of tearing the ACL, that's a really good question too, because I think what we've learned through the years is that females are potentially at a higher risk of tearing the ACL because when they're playing a sport such as soccer or volleyball or something like that, they're landing a little more straight-legged as opposed to bending their knees a little bit more. And so there actually have been programs designed to teach or to sort of retrain the landing mechanics to keep women from tearing their ACLs as frequently. Brandy's question is, can you talk about being a female orthopedic surgeon and gender discrimination? So what I would say is that for sure, there's not as many female orthopedic surgeons, but there's always good role models that are and mentors that are male and female. So I think, everyone talks about finding a mentor, this and that. It doesn't always happen that easily. That's not like, you just ask someone to be their mentor, to be your mentor, and they are. But I think once you start to, shadow, do research, those sort of things, you will, I think that's really the way to develop those relationships. And so I've been fortunate to have a lot of really good mentors that have been supportive. And then, I think probably in any field, there's always, potentially people or things that may keep you from pursuing what you really want to do. But I think as long as you kind of, stick with those that are positive, that's really that's really the best you can do, I think. And fortunately, I think there's a lot of effort in terms of trying to get more women to orthopedic surgery and just diversity in general, because that's what the patient and the U.S. population is. And so I think it's important that everyone is considered in terms of going to that specialty. Yeah, so I see a lot of tennis questions on there. So so there's a lot of different routes in terms of going into sports medicine. So you can do sports medicine not just from orthopedics, but you can also do a fellowship in sports medicine from primary care or rehab medicine or pediatrics. But the only one where you can actually do surgery is orthopedic surgery. So it's a 5-year residency for orthopedics and then 1-year sports medicine fellowship. And so during the sports medicine fellowship, that's where I got to work with professional football and hockey teams. And then when I started my practice, there was an opportunity at the US Open about 12 years ago, and then I kind of started from there. So in terms of training, I would say it's 6 years because it's 5 years of orthopedics and then 1 year of fellowship. Let's see. So examples of most common orthopedic surgeries that I do. So for sports medicine, that's obviously it's a very general term, but it's typically mainly arthroscopic surgery. So arthroscopic is minimally invasive surgery where you're making small incisions and then you're using water to blow up the whatever part of the body you're in. So either the knee or the shoulder or the hip. And so those are the most common body parts that I treat with surgery. And so that ranges anywhere from, the shoulder, there's rotator cuff tears or labral tears. In the knee, there's the meniscus tears, ACL tears. So those are some of the probably the more common things. And then in terms of what my schedule is like each week, so it's a mix of both seeing patients in the office as well as the operating room. So I really like having that mix. The 5 years is including the internship. DO school, I think, should be fine. There's definitely DOs that go to orthopedics. So orthopedic surgery is orthopedic surgery, but if you wanted to do, like, let's say you're interested in musculoskeletal medicine, but you don't want to do the surgery component, rehabilitation medicine or physiatry would be a good path, because that's dealing with musculoskeletal medicine, but without the surgical component. So the graft from the patellar tendon, that's a good question. So Thomas asked, if you take the graft from a part of the body, does that lead to any weaknesses or anything like that? So actually, no. You still get your strength back, and even though it doesn't grow back to the same, like you wouldn't take someone's patellar tendon and then take it a second time because it doesn't grow back enough to do that. But you're not taking the whole thing; you're only taking a portion of it. So people don't typically have any deficits or weakness afterwards. Would I say post-op range of motion is as fluid as pre-injury range of motion? I think that there's definitely been studies showing that the more you get somebody back to their pre-injury range, you want to do some rehab before you do surgery, because that way that can only help you afterwards. So if you have good motion before the surgery, that'll help you afterwards too. So it's really important for me that someone gets it back before surgery. All right, I think, are we done at 3 or?
You can continue to answer questions if you'd like, or it's up to you.
Okay. All right, I'll probably do a few more here. I'm not usually seeing patients outside of my specialty. Oh, the worst case I've seen. I would say the worst case is usually, unfortunately, I don't see too many of these, but I would say one in which something is done that could potentially hurt the patient, and the patient doesn't understand that how much of a problem that is. So and the doctor that's done the original surgery hasn't explained it. So no matter what specialty you go to, your relationship with your patients is really important. And again, you always want to think, like, if this is your mom or a relative in the room with you, you don't want them to leave without understanding what the problem is. And then you don't want them to, you would never want someone to not try their best when they're doing surgery on them. So the worst cases, I would say, are the ones where the patient doesn't feel like they have an understanding of what the problem was, I think you can almost always fix something that was maybe like re-injured or something like that. But if the patient doesn't understand it, then that's a harder problem to deal with. I don't usually see patients outside of my specialty, but I do have my own practice, and I work with residents at the medical school. And so Labrina said, have I ever had to correct another physician's work on a patient? So I would say not usually correct, but even though you have your ACL torn, you can always re-tear it. And that may not necessarily be the other doctor's fault, just maybe that the patient got injured again or something like that. But the revision, so we call it a revision, or like redoing of an ACL surgery that was already done, is probably one of my favorite surgeries to do. And the reason for that is because I really like the thinking that goes into it's a little more complex in terms of, okay, well, this was already done, so how do I correct what was done before? So I actually really enjoy those cases. So advice for pre-med students trying to get involved during COVID. Well, I would say this one is actually a great opportunity, I think, to do the web shadowers. In addition to shadowing, the other thing I would recommend is potentially trying to do research. So I know, most medical schools aren't allowing in-person shadowing, but with research, a lot of times you can get involved with a physician that you may not need to do anything in person. So if there's something that you're interested in, I would try to contact someone in that field. And as someone who is on the receiving end of those emails, don't be discouraged if you don't hear back right away. Sometimes people get so many emails, or they may not recognize the name. So I would either try to keep bombarding until someone answers you, or maybe see if you have a connection somehow. Like if you're at a university, maybe one of your professors might have a connection to, and it doesn't necessarily need to be an MD, but maybe someone who has like a biomedical engineering lab or some sort of science type lab, where they're doing some work that is, has some sort of relevance to medical school, and that would be a good way to get involved too. How's the environment at the Icahn School of Medicine in Mount Sinai? I would say it's extremely supportive at Mount Sinai, where I am. I went to medical school there, and I'm back there teaching. I would say it's ahead of its time too, in terms of a lot of initiatives that it has. So I think if you're looking at medical schools, it's definitely a great place to apply to. Research, I think, in any field, well, I guess let me take that back. So it's probably better if it's research that's somewhat can be relevant to medicine, but it doesn't have to be. So anything that you learn, like any skills you learn in terms of doing statistics or something like that, that's always usable later on. So let's say, if you're still not in medical school yet, or you're getting towards the part that you're applying, you still have all of medical school to do research in that particular field, but maybe something that you learn doing research now is translatable to later. So I don't think it necessarily has to be in orthopedics. Now that I'm in this specialty, has this field exceeded my expectations? I would say the one thing that, like I said, I thought was a very good piece of advice, and that I think is translatable to everybody, is that I really have made my my practice the way I want it to be, in terms of, I have 3 kids under the age of 11, and I want to spend time with them too. But I'm also a surgeon, and I work with the US Open tennis. And so you really, obviously it didn't happen overnight, but you really can make your field or make your career what you want it to be. It takes time. But again, don't cross anything off the list just because you're concerned that it might be too hard of a schedule. All right, I think that got everything there.
Thank you so much, Dr. Colvin, for presenting such an interesting case today. It was so informative, and we all learned so much.
All right, thanks for inviting me. Good luck, everyone.
And thank you, everyone, for attending. The Google form has now been posted. In the comments, please fill it out within the next 30 minutes for us to receive verification of your attendance. And thank you again, Dr. Colvin, for taking time out of your day to present this wonderful case and answering all of our questions.
Okay, you're welcome. Bye. Thanks, everyone.